I'm Divaka Perera. I'm a professor of cardiology at King's College London and a consultant cardiologist at Guy's and St Thomas's Hospital in London. The rationale of Revived was to find out whether treating patients who have severe ischemic cardiomyopathy, lots of coronary artery disease and poor left ventricular function, and actually an extra criterion, which was that they needed to have at least 4 segments of their myocardium, roughly 25% of the whole left ventricle, being shown to be viable. In other words, likely to hibernate, likely to recover once you treat the coronary disease. If they met those criteria, would they be better off with stents in addition to optimal medical therapy, or was optimal medical therapy alone the right treatment for them? So that was the question we were trying to answer. So I've already touched on the inclusion criteria for Revived, and perhaps I'll just explain it in a little bit more detail. When I said very poor left ventricular function, we meant patients with an ejection fraction less than 35%. When I said extensive coronary disease, again, we characterized that by using the British Cardiovascular Intervention Society Jeopardy score. That quantifies how much coronary artery disease that was needed to get into the trial. The worst amount of coronary disease that you could have would attract a score of 12. And to get into Revived, you needed a minimum score of 6. And then the viability criterion. So this was a prediction of the likelihood of recovery of left ventricular function using cardiac MRI, dobutamine stress echocardiograms, PET imaging, etc. So it's an imaging test that says the myocardium hasn't died, it's not completely scarred, and could recover if it was given the blood it needs. So based on those 3 tests, coronary disease, LV function, and viability, we identified our patients and randomized 700 patients to either have optimal medical therapy alone or optimal medical therapy plus PCI. And again, probably worth my explaining what we mean by optimal medical therapy. And that was titrated heart failure therapy, appropriate to each patient's blood pressure and all of their characteristics, the best medical therapy they could get, and also device therapy. So ICDs, cardiac resynchronization therapy, that's all included in the umbrella of optimal medical therapy. So they were randomized 1-to-1, and patients were followed up for a minimum of 2 years, 24 months. But actually, in some patients' case, we had follow-up for up to 8 years or so. And the primary outcome that we were interested in was all-cause death or hospitalization for heart failure. And hospitalization for heart failure was something that was very carefully adjudicated. Centers reported it to us, and clinical events committee, independent events committee, who didn't know whether they'd had PCI or were in the medical therapy arm, adjudicated it and said, yes, they had or hadn't had a heart failure hospitalization. And then there were several other secondary outcome measures as well. The 2 main ones being left ventricular function. Did the left ventricular function improve as the theory would suggest it should do? And then coming back to the patient, did patients feel better? Did their quality of life improve after PCI more than it did with medical therapy? So we'll deal with safety first because that's fairly easy. Remember, we started this trial because we wanted to see whether we could deliver revascularization more safely than surgery. And there was no signal that PCI does harm. So the mortality rates in the first 30 days, which is a good measure of whether the procedure itself does harm, were exactly the same in both arms. So that's good. It's a safe procedure. But does it work? Well, the first thing to look at is, did we put the right cohort of patients in? Are they having lots of events, or were they low risk? The answer is no. They were as high risk as we'd imagine. So in the medical therapy alone control arm, 38%, more than 1/3, had either died or had a heart failure hospitalization during the course of follow-up. So that's still a major problem. This is patients who had the best medical therapy that we can give them in contemporary practice. So it's a high event rate, but PCI didn't reduce the occurrence of that event rate. So the likelihood of a patient either dying or having a heart failure hospitalization was exactly the same throughout the course of the trial in the patients who had PCI as it was with medical therapy. So that was the primary outcome. And what was perhaps equally surprising, but explains that first result, is that left ventricular function was also not different between the two groups. It did improve with medical therapy, but there was no further improvement with PCI. It improved in all patients by a little bit over the course of the trial, but there was no difference. Quality of life, remember, was the other major secondary outcome. Now, that was really interesting. Patients who had PCI did feel better than the patients who had medical therapy alone in the first 6 months, in the first year. But by 2 years, the difference between quality of life had really diminished. And that was not because the patients who felt better after stenting then started to feel less well. They continued to feel well. But the medical therapy arm had a catch-up, and their quality of life improved. So that the differences, there was still numerically a better quality of life in the stent arm, but the difference was not statistically significant. So overall, combining all of that together, PCI doesn't seem to improve survival or freedom from hospitalization in these patients with severe ischemic cardiomyopathy. So I think our practice has largely been based on anecdote so far. So the international guideline committees, the European Society of Cardiology, for example, gave it a class 2A recommendation, which means that it should be considered, PCI should be considered in most patients, provided it's been discussed at a heart team and so on, but acknowledged that the level of evidence on which that recommendation was based was pretty weak. It was a consensus of opinion. Now we no longer need to rely on consensus of opinion. We have a proper randomized controlled trial. And the answer is we shouldn't be offering PCI to these patients for improvement of survival alone. But there are perhaps a couple of caveats that I should mention when I make that conclusion, which is that the population who went into Revived didn't have a lot of angina. They had minimal or no angina at all. And if there are patients who have lots of angina, coronary disease, poor left ventricular function, I think that's still a very reasonable treatment to offer them for control of symptoms, but not necessarily to improve the life expectancy of patients. But it's also indirectly a sign that medical therapy really has improved a lot over the last 20 years. But despite all the improvements, we can't rest on our laurels, because 38% of patients who had medical therapy were either being hospitalized for heart failure or had died. So there's still a lot more that needs to be done. It's just that PCI doesn't seem to be the answer.